Consider these clinical situations. A patient is being taken for surgery, and before that or during the course of surgery, the patient is administered IV fluids. And the moment IV fluids are administered, there is reflex tachycardia in the patient. Now, this can be a potentially hazardous situation whereby the blood loss can increase during the surgery and it could be even fatal. Or a person is being taken for angiography, and during the angiography, the dye is injected and the dye is followed radiographically, and its images are taken. So when the dye enters the coronary arteries, which is for which the angiography is done, when the dye enters the coronary arteries, suddenly there is reflex bradycardia in the patient, hypotension, apnea. Or let's say patient of ischemic heart disease, and the patient is being thrombolized. Thrombolysis being done, and thrombolytic agent is administered in the coronary vessels, because there is that's where the thrombus is formed, atherosclerosis is there. So when you administer the thrombolytic agent, suddenly there is apnea and bradycardia, hypotension in the patient. These are the real situations where some kind of a cardiac reflex or cardiopulmonary reflex was initiated, and the situation suddenly became worse. So in this video, we are going to discuss two important cardiac reflexes: Bezold-Jarisch reflex and Bainbridge reflex, and we will try to understand what is the clinical significance of these reflexes. Now, the first things first, there are receptors located in various parts of the heart and lungs. I beg your pardon, heart and lungs. They are in the juxtacapillary region of the alveoli, that is in the interstitium of the lungs, where they are called J receptors. They are in the atria, they are in the ventricles, they are in the great veins, they are in the pulmonary trunk. At these various loci or locations, there are these receptors. They can be stimulated by various triggers, and what is initiated is called as the cardiopulmonary reflexes. In this video, we will talk about the cardiac aspect of it, cardiac reflexes initiated by the cardiac receptors, although they will have some kind of a pulmonary response as well in the form of apnea. So the two reflexes that I am mentioning, the Bezold-Jarisch reflex and the Bainbridge reflex. Let's start from the basics. There are receptors in the atria, there are receptors in the ventricles. Receptor in the atria are stimulated when you get the response, that is Bainbridge reflex. Receptors in the ventricle, when they are stimulated, the response is the Bezold-Jarisch reflex. Point number one. We are going to discuss these reflexes separately, the reflex responses and so on. But for now, let's compare and understand the difference between these two reflexes. Atria, they mainly have mechanosensitive receptors which are stimulated in the Bainbridge reflex. Ventricles have chemosensitive receptors. They are stimulated by the chemicals, and that is when the Bezold-Jarisch reflex is the response. And the third most important aspect here is, whenever the atrial receptors are stimulated, the response is tachycardia, that is in the Bainbridge reflex. Whenever the ventricle receptors are stimulated, the result is bradycardia, which is what is seen in the Bezold-Jarisch reflex. Let me just add one more point here, and that is, when we say receptors in the ventricle are stimulated, where are those receptors located? Well, those receptors are located either in the wall of the ventricles, particularly in the endocardium region, or in the coronary vessels supplying the ventricular musculature. I repeat once again, the receptors that evoke Bezold-Jarisch reflex, they are located either in the wall of the ventricles or in the coronary vessels that supply the ventricular myocardium. With that in mind, let's start the first one, and that's Bezold-Jarisch reflex. Activation of chemosensitive vagal fibers or C type of fibers. C fibers or are unmyelinated fibers. Point number one. And they are stimulated. They are located in the cardiopulmonary region. We mentioned some of the locations over there. Juxtacapillary region of the alveoli. I'm talking about broadly the cardiopulmonary reflexes. So I included J reflex as well in this. But anyways, it causes, whenever these receptors are stimulated, it causes profound bradycardia and hypotension and a brief period of apnea followed by rapid shallow breathing. So I want you to repeat once again the responses. The response in the heart is of cardiac depression, that is hypotension, bradycardia, and response in the lungs in the form of apnea and followed by rapid shallow breathing. So even in the case of lungs, it's apnea, cessation of breathing. So it is inhibitory, and therefore all in all the Bezold-Jarisch reflex, we can say that it's an inhibitory type of a response obtained in this reflex. This is called Bezold-Jarisch reflex, also called as coronary chemoreflex. Coronary chemoreflex, also called as ventricular chemoreflex. Yes, this is the better term, ventricular chemoreflex. It will sum up the entire thing for you, because receptors are in the ventricle and they are stimulated by a chemical stimulus. Alright, so ventricular chemoreflex, also called as cardio inhibitory reflex. Yes, hypotension, bradycardia, and so therefore these are the various names for this reflex. Well, it was the first reflex to be recognized as a non-mechanical reflex. Normally, until the in the previous century, these reflexes were studied in detail, and what was found with that, most of the reflexes were triggered by mechanical stimuli. Bezold-Jarisch reflex was the first reflex to be identified as a non-mechanical stimuli evoked reflex. And non-mechanical mean the chemical stimuli and chemical reflex. Initially, it was put forth by von Bezold and later revisited by Jarisch, and therefore the name Bezold-Jarisch reflex. While they were studying the reflex, they injected various chemicals, and that is how they found out this response. The various chemicals, mainly they injected intravenous veratrum alkaloids. Veratrum alkaloids were injected IV. It went into the ventricles, it went into the coronary vessels, and then it evoked the response. So veratrum alkaloids like veratridin or capsaicin, serotonin, snake venom, nicotine, etc. And these chemicals were injected. That is when they found this reflex. Alright. The question now arises is, veratrum alkaloids are not present physiologically in the human body. So why do we have to know these reflexes at all? They were found after injection of veratrum alkaloid or some other chemical. Then what is its significance in the human body? Yes, that's the moot question. Bezold-Jarisch reflex is activated during certain pathophysiologic conditions which are found commonly, routinely in the humans. For instance, myocardial ischemia, particularly when there is posterior wall myocardial infarction or inferior wall MI, and often it is accompanied with hypotension, a very stubborn hypotension where it's difficult to treat. That is when it is thought that Bezold-Jarisch reflex has been triggered in such posterior wall MI cases. Or after the myocardial after the ischemia, if there is reperfusion, then again hypotension, bradycardia, and it becomes difficult to treat such a patient. What I'm saying is, why do we have to know about this reflex? Yes, if we are aware of this reflex, then we are better positioned to treat the patient accordingly. You are conscious about this reflex, that it can be triggered, and accordingly you can handle the situation. So therefore it is necessary to understand these reflexes. So reperfusion and how these reflexes are triggered. Whenever there is in the conditions of acute MI, particularly posterior wall or inferior wall MI, release of noxious chemicals and stimulation of a particular receptor. Now it is interesting. The receptor is TRPV1. It's a receptor and a channel associated with it. Remember TRPV1? TRP is transient receptor potential, superfamily of receptors, which responds to noxious stimuli or noxious chemicals like capsaicin. And this channel is also found, TRPV1, V stands for vanilloid. This channel is also found in the coronary arteries, which is where it gets stimulated after the inferior wall MI, resulting in Bezold-Jarisch reflex. Or during reperfusion, you must be aware of this fact that after ischemic time period, when there is reperfusion, perfusion is re-established, there is generation of reactive oxygen species, and these ROS are also responsible for Bezold-Jarisch reflex. So various clinical settings in which you get this reflex. Okay. Or yes, furthermore, angiography, yes, by the agents used as radio contrast during coronary angiography. Yes, the radio contrast material is injected and radiographically followed. When it goes into the coronary arteries, that is when you obtain that radiogram to study how it is spreading and whether there is a block in the coronary arteries. But then it is going into the coronary arteries, and the receptors, the chemosensitive receptors, are located there in the coronary vessels, so they will respond to this chemical. And during the angiography itself, there would be apnea and hypotension, bradycardia shown by the patient. Or coronary injection of thrombolytic agents, when there is a thrombus formation resulting in the ischemic heart disease or infarction, and thrombolysis is being performed on the patient. You instill the thrombolytic agent into the coronary artery, and it's a chemical. So just have a visual impact of this, that injected those particular chemicals like a radio contrast dye or a thrombolytic agent during the angiographies or angioplasties or such procedures, and it goes into the coronary arteries, and the receptors are located over there. So those chemical agents trigger the Bezold-Jarisch reflex during the procedure itself. If you are aware of this, then you can handle the situation clinically much better. That's the reason that we should know these reflexes. All right. And this can be a reason for hypotension, which is a very common complication in these situations, like in MI or during reperfusion. Hypotension is a common occurrence, or as I said, inferior wall MI is commonly associated with hypotension. And why is that? Possibly the Bezold-Jarisch reflex. Having said all of this, when do we get the reflex? Let's see the pathway for the reflex. One thing that you should understand is that it's a cardio-inhibitory reflex. That means the heart is going to be inhibited, and along with that there is going to be vessel dilation, blood vessel dilation. So hypotension by peripheral vessel dilation and inhibition of the heart. So bradycardia, hypotension, and the respiratory response, apnea followed by rapid shallow breathing. So of course bradycardia will result when sympathetic support to the heart is withdrawn. Sympathetic discharge stops and parasympathetic discharge increases suddenly and massively. That is when we get this reflex. All right. If you want to compare this with the Bainbridge reflex, which is associated with tachycardia, the reverse happens in that reflex. That is, vagal discharge is withdrawn and sympathetic massive discharge occurs to the heart, resulting in the tachycardia. That is in the Bainbridge reflex. In the Bezold-Jarisch reflex, let's see, the reflex is initiated by stimulation of non-encapsulated, unmyelinated type C vagal afferents. So we are looking at three things. What are the receptors and the afferents? They take the signals from the heart to the center. Then there is a center, that's the second part. And what are the efferents that finally produce the response? So starting with the receptor non-encapsulated and unmyelinated type C fiber of the vagus. So this is the receptor and the nerve ending which will take the impulses further. So vagus will carry the impulses from where it generates the signal, from the wall of the ventricles or from the walls of the coronary vessels inside the myocardium. All right. So unmyelinated vagal afferents and type C, you know this, that A alpha, A beta, A gamma, A delta, B and C, 6 types of nerve fibers, out of which A and B are myelinated, C is unmyelinated. We are talking about those type C fibers here. Again, one more difference. In the Bainbridge reflex, it will be initiated by the myelinated nerve endings, A or B type. Here, it's by C type. And then signals arise from the heart, they go to the higher CNS centers, then autonomic nuclei in the medulla get the signals, and finally the response via the efferents. There is abolition of the sympathetic discharge. Sympathetic discharge is withdrawn and massive stimulation of the vagus firing, parasympathetic discharge, and therefore obviously there is vasodilation and there is hypotension because of the vasodilation and bradycardia. It is also experimentally found that in this reflex, Bezold-Jarisch reflex, and in many other reflexes, the vasodilation, peripheral vasodilation, is independent of the heart rate modulation. I mean, many a times we tend to think that the blood pressure and heart rate go hand in hand. If one is changed, the other is going to be invariably changed. Well, that's not the case. At least not here, that it always happens. But yes, generally speaking, peripheral vasodilation can be independent of the heart rate modification. So, these two responses can be independently generated. What is the overall significance of cardiopulmonary reflexes? First, we saw what is the significance of Bezold-Jarisch reflex. When is it triggered and why is it triggered? And it makes you ready for such a reflex so that you can handle the clinical situation better. But generally speaking, what is the overall significance of cardiopulmonary reflexes? Let me take an example. Suppose a toxic material has been inhaled. Toxic gas or toxic material, chemical has been inhaled. It will stimulate those pulmonary interstitial receptors, the J receptors, and it will produce the same response, apnea followed by rapid shallow breathing and bradycardia and hypotension. Now this is a protective reflex, and of course all the reflexes generally are protective. They are for the protective purpose. So even these reflexes, cardiac or cardiopulmonary in general, overall protective. How? See, there is toxic chemical being inhaled, so apnea will stop the ventilation temporarily so that the more and more chemical does not go into the blood, and whatever has gone into the blood can be easily eliminated out of the body so that vital organs are protected from the effects of that toxic chemical. That is probably the protective mechanism or protective basis of these reflexes. There will be apnea, so the toxic chemical stops and not get inhaled any further into the body, etc., etc. That's the overall significance of these types of reflexes. All right, just last one more point. Although we said that this is a chemical reflex initiated by the chemicals, the Bezold-Jarisch reflex, often it overlaps with the mechanical reflexes. For example, vasovagal syncope, vasovagal syncopal attack, fainting attacks. Those attacks are triggered after, let's say, emotional trauma or sudden painful stimulus to the body part. Now, those reflexes are initiated by mechanical stimuli, but they are thought to be also a part of Bezold-Jarisch reflex. So these two reflexes, the mechanical reflex and the Bezold-Jarisch reflex, often is shown to overlap. All right, the purpose of such reflexes is generally not very clear, but as I mentioned, you can be at least clinically aware that such a reflex can happen. If the inferior wall MI patient comes, you can be aware that the patient might go into hypotension. All right, that was Bezold-Jarisch reflex. Now coming to the Bainbridge reflex. Most of the things we have already mentioned in the previous part, that the Bainbridge reflex is triggered by stimulation of mechanoreceptors in the atrial wall, right? So increase in the heart rate secondary to an increase in the central blood volume. That's the definition of Bainbridge reflex. Increase in the heart rate, mind you, and it's easy to remember like this, that if the central blood volume increases, venous return to the heart, right heart increases, and right heart means right atrium, and SA node is located in the right atrium. So imagine like this, for the sake of understanding, that the blood returns to the right atrium, right atrial filling increases, and SA node is embedded in the wall of the right atrium. SA node begins to discharge more number of impulses and the heart rate increases, tachycardia happens. Remember it like this, we will eventually see the pathway for the reflex. Okay, so it triggers the tachycardia. Physiologically, when does that happen? Okay, deep inspiration, deep and forceful inspiration. It results in sinus arrhythmia, sinus tachycardia, or sinus arrhythmia rather. More blood volume is sucked towards right side of the heart with deep forceful inspiration. It will trigger the Bainbridge reflex, or change of posture, and suddenly more blood will return to the right side of the heart, or person going into zero gravity. You see, because of the gravity, more blood is pulled into the lower extremities, and therefore less venous return to the heart. But in zero gravity, the venous return will increase. So all these are real life situations which will trigger the Bainbridge reflex. And of course, increased blood volume due to intravenous saline. I mentioned the scenario that patient is going for surgery and being administered IV saline, and suddenly there is reflex tachycardia and other responses. So increased right atrial filling, and as I mentioned, stretch receptors in the wall of right atrium, they will be stimulated. So a key difference, Bezold-Jarisch reflex, chemical receptors or chemoreceptors were stimulated. Here, stretch receptors are stimulated. Signals are sent to the nucleus of tractus solitarius, and now watch this. In this case, in the Bainbridge reflex, there is sudden withdrawal of the vagus and increased sympathetic firing. And therefore, obviously, there is reflex tachycardia. Parasympathetic discharge stops and sympathetic discharge occurs massively. Significance, okay, increased preload on the heart. Look, increased venous return means increased preload on the heart. So heart responds by increasing the heart rate and therefore increasing the cardiac output. Load on the heart has increased. Heart is responding to it by pumping more blood and increasing the cardiac output. That's the clinical significance of the Bainbridge reflex. Finally, just to add, there is also a reflex called as Harrison's reflex. Reflex acceleration of the respiration due to increased intra-atrial pressure. So this is in the form of increased respiration. So I've mentioned it in the end that there is reflex acceleration of the respiration in response to increased intra-arterial pressure, Harrison's reflex. Don't forget, sometimes this is asked in the multiple choice questions. But anyways, that was in a summary the cardiac reflexes. In the next video, we will also see the pulmonary reflexes, particularly the J reflex.